Good night.
Good night.
Okay, good. All right, so this is lecture 5 in our heart failure lecture series. And what we did in the previous 4 lectures, we define heart failure. We look at the different stages of heart failure and the class of heart failure. We look at the epidemiology, the risk factors, and now we have come to the treatment. So what we're going to do is to divide the treatment of heart failure in the different stages. So we'll look at the treatment in stage A and B, and then we will go on to the treatment in stage C, heart failure. And then when we come to refractory stage D, heart failure, we're going to have a two-prong approach, if you want to call it that, where we look at medications, and then we look at mechanical cardiac support. So that's how we are going to approach it. We're going to start with stage A, heart failure. So you should recall what is meant by stage A heart failure. So again, when we talk about stage A, we talk about someone who have risk factors for heart failure, but asymptomatic. Clinically, they have not developed heart failure. So all they have is the risk factors. And it's important that you treat these individuals very aggressively so that they don't go on to develop clinical heart failure. So one of the things that you have to do is recognize and treat elevated blood pressure, hypertension. And, we did a very extensive lecture series on blood pressure. And what we're going to do here is not going to be exhaustive. So if you want to review the hypertensive lecture series, that would be a good thing to do. But anyway, elevated blood pressure is a major risk factor for the development of both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And we recommend that you treat these patients per guidelines. Okay, I mean, all of us know how to treat blood pressure, but you should follow the guidelines. Also, what about dyslipidemia and vascular risk? Okay, so remember again, stage A, heart failure, patients, all they have is risk factors. So patients with known atherosclerotic disease are also more likely to develop heart failure. So the aggressive treatment of dyslipidemia with statins reduce the likelihood of heart failure in at-risk patients. So we have done very extensive study looking at statin, and just like hypertension, we put these patients into risk groups, and we can either use low intensity statin, moderate intensity statin, or high intensity statins. So we will also review statin guidelines at some point in time. Also, the long-term treatment with ACE inhibitors in patients with these risk factors may also decrease the risk of developing heart failure. So, treating the risk factors for heart failure does prevent the development of clinical heart failure. So what about obesity and diabetes? So we know that these are risk factors for heart failure. Insulin resistance, either with or without diabetes, is also an important risk factors. And especially diabetes in women, this will triple the development of heart failure in these individuals. So you should be aggressive in terms of treating these diabetic patients. Um, Studies have shown that if you look at the hemoglobin A1C, hemoglobin A1C, as you know, it's give you an accumulative diabetes control over the previous 3 months. So if the hemoglobin A1C is greater than 10.5%, patients usually have a greater than fourfold increase in risk of heart failure as compared to those with a hemoglobin A1C of less than 6.5%. So, so if your sugar is chronically not well controlled, you have an increased risk of developing heart failure. And the standard therapy for diabetes, using medications such as ACE inhibitors or ARBs, can prevent the other risk factors that cause heart failure, such as renal dysfunction. So we're still on stage A heart failure. So again, stage A patients, all the patients have is the risk factors. They're asymptomatic. Okay. Um, the recognition and control of other conditions that may lead to heart failure. Remember, we said patients with atrial fibrillation, especially if the atrial fibrillation have its accompaniment, rapid ventricular response. If the heart rate is very high, those patients can develop a tachycardia-induced cardiomyopathy. As a matter of fact, any type of rapid heart beat over a long period of time can give you this um, tachycardia-induced cardiomyopathy. So if you have a patient that comes in and they're chronically, it may be inappropriate sinus tachycardia or whatever type of tachycardia, you should try and treat it. And if you can control the heart rate or convert the rhythm from an abnormal one to a normal one, you should do that. Alcohol is also a very, very common cause of heart failure with reduced ejection fraction, and we went over this before. So every use of alcohol is associated with the development of heart failure. So you ought to counsel these patients and see if you can get them off the alcohol. So medications, and if you those of you who work in the echo lab have seen we have a lot of referrals for patients who are taking chemotherapy or who are going to take chemotherapy because of breast cancer or lung cancer. And the cancer doctor wants to get an ejection fraction before they start the medicine, or they want to get an ejection fraction during the course of treatment or after treatment with these agents. So you have to be very vigilant, because you don't want the patient to be, you treat the patient for a malignancy and then they develop a cardiomyopathy. So agents that you're going to be concerned about is your anthracycline based chemotherapy, the trastuzumab, which is the Herceptin. And there's a lot of patients taking Herceptin for breast cancer these days, and they come to the echo lab because they want to know what's going on with the ejection fraction before they get started on it. So you're going to evaluate the LV function in these patients, and and follow them up, make sure there's no damage from these medicines. What about tobacco use? Yes, tobacco use is strongly associated with increased risk of heart failure. So you should advise your patients about the hazards of smoking and discuss smoking cessation programs with them. So that's stage A. So stage A, risk factors, you're going to spend more time counseling your patients. You know, if they have blood pressure problem, you treat it. If they're diabetic, you treat it and, you know, give them education. You know, if they're taking any other substance that can cause heart failure, you're going to counsel them on those substances. Now, your stage B patients, these are patients with structural heart disease, but they're asymptomatic. So they're a little bit more advanced than your stage A because they now have structural heart disease. Clinically, they have no signs of heart failure, however. So one of the things these patients going to have is reduced ejection fraction. So some of them will have reduced ejection fraction, and you have to treat these patients. So they come to, say, the echo lab, and they come to the echo lab for pre-op clearance. Ejection fraction was found to be 35–40%. You have to treat them. Okay, patients with valvular lesions need treatment as well. So, you know, I don't mean you're going to do valve operation, but, you know, whatever intervention you can carry out, it might just be counseling. You know, you're going to do that to prevent the valvular problem from getting more severe. Congenital lesions are the same thing. And, you know, your stage B patients, all the counseling that you do for your stage A heart failure patients, you're going to apply that to your stage B patients. One of the things that we know is that patients who have had a heart attack, so if you had a heart attack, the 5-year risk of heart failure after a heart attack, if you're age 40 to 69, it's about 7% for males and about 12% for females. So heart attack 5 years after that event, if you're between 40 and 69, 7% of males will develop heart failure and 12% of females. If you're older, you know, great, if you're older than 70, then 5 years after this heart attack, 22% of males and 25% of females will develop heart failure. So you see that coronary artery disease, you know, having a heart attack is a significant risk for developing heart failure. And one of the things that you'll hear from time to time is remodeling. When you have a heart attack, the infarcted muscle remodels, and even the non-infarcted muscle also remodels. It thins and dilates, and that will give rise to heart failure. So when we see our patients with stage B heart failure, if they have a low ejection fraction, so the patient who comes to the echo lab pre-op clearance and found to have an ejection fraction of 35–40%, those patients should be on an ACE inhibitor and a beta blockers, okay? And it has been shown that these medications improve mortality and morbidity. It makes the patients live longer and makes them less sick. So asymptomatic LV systolic dysfunction, ejection fraction less than 40%, these patients should be on an ACE inhibitor and a beta blocker. We can substitute a HARB for ACE, so angiotensin receptor blocker is a reasonable alternative to the ACE inhibitor if the patient is intolerant of the ACE inhibitor. You know, in these patients, beta blocker is a little bit less convincing, but there's some mortality benefit. And carvedilol in patients with coronary artery disease is associated with a 31% relative risk reduction in adverse long-term outcomes. So these are stage B heart failure patients, asymptomatic. So medications that are known to have a negative inotropic property, that is, it weakens the contractility of the heart muscle, it should be avoided. So if you have someone who asymptomatic, ejection fraction 35 to 40%, you should try not to give them your non-dihydropyridine calcium channel blocker. And we went over this before, but your diltiazem, that is the cardizem and the verapamil, you should not prescribe these calcium channel blockers to your patient with depressed LV systolic function. These medications have what we call a negative inotropic effect. And then when we say inotropic, we're referring to contractility of the heart. Also, there were studies done. One of the studies, the landmark trial, was the CAST trial. And it has been shown that if you use certain antiarrhythmics, these are medications that will quiet down arrhythmias. If these antiarrhythmics have negative inotropic properties, then there's increased mortality in your patient. So, we don't give flecainide and propafenone to someone who have a reduced ejection fraction. Okay, so these are some of the things that you need to know. Okay, you can't give your patient medication that is going to compromise or cause death. So again, blood pressure, elevated blood pressure is known to give rise to LVH, left ventricular hypertrophy. And if you treat the hypertension, you can treat the LVH, and it also reduces the heart failure events. Now, you can't move if you understand the different stages. You really can't move from a stage B to a stage A, because again, the definition for this stage A is just patients with risk factors for developing heart failure. Your stage B patient have actual structural heart disease. So you can't move from a structural heart disease to a non-structural heart disease. You already have structural heart disease. So you can't move from stage to stage. So again, stage B heart failure patients, several large trials that show that if you control the blood pressure adequately, you can decrease the risk of heart failure by 50%. So adequate blood pressure control is very important. And the diuretic-based antihypertensive therapy have been shown to prevent heart failure. These are the longer-acting diuretics, such as your chlorothalidone and your hydrochlorothiazide. So those medicines does help. Okay, and remember, even though they have some diuretic properties, the main thing in these hypertensive patients is blood pressure control. They may not have any significant diuresis, but they're going to have blood pressure control. In refractory hypertension, you're going to use your aldactone or your eplerenone. Okay, so it's important. Okay, I have a very low threshold for using aldactone in my refractory hypertensive patients. Okay, so remember that if the patient blood pressure is difficult to control, you have aldosterone there. Also, the ACE inhibitors and the beta blockers are very effective in preventing clinical heart failure. So asymptomatic depressed LV systolic function patient ought to be on an ACE inhibitor and a beta blocker. And if the patient have type 2 diabetes mellitus, then ACE inhibitors and HARB significantly reduce the incidence of heart failure as well. So these medications are cornerstone in the treatment of your stage B heart failure patient. And when you look at the Framinon heart study, 60% of patients, there's a 60% increased risk of death in patients with asymptomatic low EF. And, so just look at you have an ejection, you come to the echo lab, pre-op clearance, nothing about your heart, no symptoms, but you have an ejection fraction of say 35, 40%. Okay, 60% increase risk of death in these patients. And, at the time of death, half of these patients remain free from heart failure symptoms. They never had any heart failure symptoms. So one of the things, a low ejection fraction, these patients are prone to arrhythmias. So they can develop ventricular tachycardia, ventricular fibrillation. So that could be one of the mechanisms of death. And if you look at the MADE-2 trial, so the MADE-IT, this acronym stands for Multi-Center Automatic Defibrillator Implantation Trial 2. So the MADE-2 trial, what they did, they look at patients post myocardial infarction. So the patient had a heart attack and the ejection fraction less than 30%. Okay, they put a ICD, an implantable cardioverter defibrillator, in these patients. Okay, so patient didn't have any heart failure symptoms. Just after the heart attack, they had an ejection fraction less than 30%, and they prophylactically. So when we say prophylactically, that means they put in the device before anything happened. Nothing didn't happen. They just put the defibrillator in place. And what they found was a 31% relative risk reduction in all-cause mortality. So all-cause death was reduced by 31%. So the ICD, or the implantable cardioverter defibrillator in these patients, did prevent death. So now we're going to move on to our stage C heart failure patients. So we look at stage A, we look at stage B. Stage A and B are asymptomatic patients, or stage A patients, all they have is the risk factors for the development of heart failure. Stage B are patients with structural heart disease, still asymptomatic. Now, our stage C patients, this is our common patients who they have structural heart disease and they probably had previous heart failure symptoms, clinical features, or they currently have clinical features of heart failure. Numerous studies have shown that education is very important in these patients. So just educating the patient has been shown to be very, very effective. And it's a class 1 indication. Class 1 indication. So you have to educate the patient about self-care, how to take care of themselves, how to monitor symptoms, and again, weight. We recommend that these patients do daily weights, okay? And explain to them why they're doing the daily weights, because one of the most accurate means of assessing fluid retention is the weight. And if, we usually say if you gain more than 3 pounds in a 24-hour period, it's more than likely fluid. Educate them in terms of diet, sodium intake, because the diet that we're really pushing in our cardiac patients is the Mediterranean diet and the DASH diet. So those diets should be encouraged. Talk to them about their medications, why they're taking certain medicines, physical activity, we encourage these patients to exercise. And you have to know what type of exercise to give them. We don't want them to do anaerobic exercise. It should be aerobic exercise. And then after, if they're, so when they're discharged from the hospital, um, you need a disease management program. They need to be enrolled in some program that monitors them after discharge. And this post-discharge monitoring program has been shown to decrease re-hospitalization and even death. Okay, so the educational intervention studies have shown that when you educate the patient, they do have good knowledge and they can do self-monitoring. There's more adherence to their medication, and the time to hospitalization is much greater, and the days in hospital is also less. So patient education is very, very important in the management of heart failure. Social support is also extremely important. So you have to make sure that the social support program is good. So it is sort of buffer stress. It promotes treatment adherence as well, healthy lifestyle, and it has been shown that the lack of social support is associated with higher hospitalization and mortality risk. So education, social support is very important. So we talk about sodium restriction, salt and water, fluid restriction. Uh, the sodium restriction in hypertension, the robust studies that have shown that the sodium restriction in hypertension is one of the important aspects in terms of treatment. But with heart failure, the data are modest because sometime there's some period in the course of the heart failure uh, progression that you don't want to restrict the sodium. Okay, so the association between dietary sodium intake and fluid retention and the risk of hospitalization is one that you should understand, because again, there's some aspect in the patient care you don't want to restrict the sodium too much. What we know is that sodium homeostasis is altered in patients with heart failure. So it is not going to be the same as in someone without heart failure. And these are the recommendations for sodium restriction in heart failure patients. So it gets a class 2 indication. So it's not a class 1, it gets a class 2A indication. And it states that sodium restriction is reasonable for patients with symptomatic heart failure to reduce congestive symptoms. All right. And the American Heart Association recommendation is that if you have stage A and stage B heart failure, it should be about 1,500 milligrams sodium per day. And if you have stage C, then you can be a little bit more tolerant of the sodium, because some of these patients, their sodium is very low, so you don't want to lower the sodium too much. So for stage C patients is less than 3,000 milligrams for symptom improvement. And this is the AHA recommendation. So this is the guidelines that was established a few years ago. And then at the end of our lecture series, we'll go over the updates. So we always give you the full guidelines, and then we'll discuss the updates towards the end of the lecture. It has been shown that sleep disorders are fairly common in heart failure. And there one study looking at chronic heart failure patients who found about 61% of these heart failure patients had central or peripheral or obstructive sleep apnea. So sleep apnea is very common in heart failure patients. And if you suspect that someone has sleep apnea, then you should refer them to get a sleep study. Okay. So this is the recommendation for sleep disorders, the treatment of sleep disorders. It has a class 2A indication, class 2A, and it recommends continuous positive airway pressure. This is CPAP. It can be beneficial to increase left ventricular ejection fraction and improve functional status in patients with heart failure and sleep apnea. So what it is saying is that if you have a heart failure patient and they have sleep apnea, you should get them, these patients should be studied, and if they require CPAP, CPAP will help them. Continuous positive airway pressure will help them. It can improve the ejection fraction and functional status. So nocturnal continuous positive airway pressure going to decrease the apnea and hypopnea index. It's going to decrease the sleep apnea index. It's going to improve nocturnal oxygenation and increase ejection fraction. A lot of good stuff. It's also going to lower the norepinephrine level. As you know, that patients who have heart failure tend to have high norepinephrine level, and that portends a poor prognosis. So it lowers the norepinephrine level. It also increased the 6-minute walk distance, so you can walk longer in 6 minutes. And this benefit is sustained for up to 2 years after. So what about weight loss in our stage C patients? Again, obesity is defined as a body mass index greater than 30 kilograms per meter squared. And it has been found that patients with a BMI between 30 and 35 kilogram per meter squared have lower mortality and hospitalization rate than those with BMI in the normal range. So again, people who are doing an exam, they need to pay attention to this because they like to give you this little thing. So if you have on a little bit more weight, you tend to do a little bit better, lower mortality and lower hospitalization than if you have a normal body mass index. But if you're at the other extreme now, so if you have what we call cardiac cachexia, that is, significant weight loss, and if you have heart failure and significant weight loss, what it is telling you is that you have higher energy expenditure associated with the heart failure. So you're burning up a lot of energy, and you're going to lose weight, muscle mass, as a matter of fact. So cardiac cachexia is independently, it predicts a worse prognosis. So bear that in mind. And then morbidly obese patients also have a worse prognosis. So if you're thinking about it, this weight and mortality is going to give you a sort of U-shaped curve. At the different extremes, increase mortality, and then the sweet spot is right in the middle. So if you're a little bit obese, you tend to do very well. If you're very wasted, you're not going to do that well. And if you're morbidly obese, you're not going to do that well as well. What about exercise prescription and cardiac rehab? Again, people doing exams need to pay attention to this because these are, stuff that have been shown to work. So exercise training in heart failure is safe. So you need to encourage your patient to do some aerobic exercise, and you just walk. Okay, encourage them to walk. Cardiac rehab has been shown to reduce mortality, improve functional capacity, exercise duration, and health-related quality of life index. So cardiac rehab And that's the reason why most institutions have a cardiac rehab program, because it reduces mortality, improve functional capacity, increase exercise duration, and quality of life is also improved. And it also reduces hospitalization, so patients don't go to the hospital that often. It improves endothelial function, it blunts catecholamine spillover, and increase peripheral oxygen extraction. Now, before we go on to the pharmacologic treatment of heart failure, we're just going to review a few pathophysiology of heart failure. So this is nothing complex. So this is a graph, and on the horizontal axis, we have the pressures, and we call this the preload. Okay, so preload, and then on the vertical axis, we have the stroke volume. So if you look at the preload as the let's simple, you know, the heart is getting blood, the heart is receiving blood, and the blood is going to cause the heart muscles to stretch, and that's what we call the preload. So, you know, think of it as the blood going to the heart, causing the heart muscle to stretch. That's a preload. And when the heart muscles stretch because a fair amount of blood is getting into the heart, okay, so in diastole, the heart fills with blood and the muscles stretch, and then it contracts, okay, and then it's going to eject blood from the heart. So the amount of filling in the left ventricle, we just stick into the left side, the amount of filling in the left ventricle is going to determine how much blood is pumped out of the heart. And we're talking about a normal heart now, okay? So when we plot the stroke volume, so again, the definition for stroke volume is the volume of blood that is pumped out of the left or the right ventricle per beat. So per cycle or per beat, the amount of blood that's pumped out. So one beat would be in diastole, the left ventricle fills with blood, and it fills to a certain amount. And then when it's filled to that amount, it's going to contract and pump the blood out. So to get the stroke volume, you need to know the volume of blood that's in the heart in diastole, and then the volume of blood that's in the heart in systole. And if you subtract the systolic volume from the diastolic volume, you get what we call the stroke volume. That's the volume that's pumped out of the heart per beat. And then if you multiply the stroke volume by the heart rate, you get the cardiac output. So that, you know, we usually talk in terms of cardiac output. So it's just the stroke volume divided by the heart rate. And this is the normal curve, okay? And it's called the Frank-Starling curve. And this is what it looks like. So again, as we said, the preload is on the horizontal axis. So if you stretch the heart, so the greater the stretch, the greater the output. The greater the stretch, the greater the output. So, you know, you can see, you know, so at this amount of preload, if you come straight up to the normal curve, you know, you're going to get this amount of stroke volume. If you get a greater stretch or you get a greater output up to a certain point, because you now have the plateau phase, and then not only the plateau phase, then it sort of curved down. But this is the normal curve, as opposed to the curve in a patient with heart failure. So someone with heart failure with reduced ejection fraction, the curve is to the right, and it's right there. So for the same preload, you're going to get less output. So for the same preload, you're going to get less output from the heart. Okay? And that's because, you know, the heart muscle is weak and it cannot pump out sufficient amount of blood. So this is the curve for the failing heart. Okay, when we give therapy, we always try to see if we can get back to a normal curve. So when you're using any medication to treat your heart failure patient, always remember your curves. You want to get your curve looking close to the normal curve. You want it to get as close to the normal curve as much as possible. So even though we studied this in medical school, in clinical medicine, we still use it, okay? So remember that. So, all right. All right, so let's do this. All right, so all right, let's look at this curve. All right, so this is our normal curve, okay? Frank Starling, I mean, the preload, so if you're giving enough blood to the heart and stretching the heart, that's a preload. And then we can look at the stroke volume, and we multiply the stroke volume times the heart rate, we get the cardiac output. This is our normal curve. This is the curve for a failing heart, okay? So, someone comes to your office or you see someone in the hospital and say they're right here. So this is a decompensated patient. This patient is really sick because they're on the descending limb of the failing curve. So this is a curve because, again, if you compare to your normal curve and you take any preload, if you take any preload, let's take any preload. So let's take preload 15, okay? This is our preload 15. The normal curve, a normal person will be able to eject this amount of cardiac output. The failing heart is going to just do this amount of cardiac output, which is very low, okay? But if you write here, when you get the patient here, this patient is huffing and puffing. This patient is very short of breath. So one of the first things you would do, you would decongest the patient and you give them diuretics. So you're going to move from, say, this point here to a more favorable point in the curve. So you move them up here, okay? You're not going to, so diuretics, which is the mainstay for patients who are congested, is just going to move them to a more favorable point in the curve. So your diuretics is just for symptom improvement. Diuretics only improve symptoms. Okay, so you're going to move them from here to there, but they're still going to do better because remember, when you're here, your cardiac output is there, as opposed to when you're up here now. Okay, so when you're up here, your cardiac output is going to be more. So even though you're on the same failing curve, you're going to bring them to a more favorable point. But you want to do much better. You always want to thrive for the normal curve. So one of the things that you can do to move your curve to the left is to give them something that can increase contractility. So you want to give them something that can increase contractility. And they have digoxin here, and digoxin doesn't increase contractility modestly. So you would move from this curve. So if you give them a medicine to improve contractility, you will trace a new curve. It's not going to be on the same curve. They're going to trace a new curve, which is going to be to the left of the failing heart curve. So you see, this is a more favorable curve because it's now approaching the normal curve. And for any preload, you're going to get a much greater cardiac output. So given a medication that will increase contractility is going to move the curve to the left. But you can do better. you know, in addition to increasing contractility, you can also decrease afterload. Now, afterload is the force that the heart encounters when it pumps blood out, and it's gonna include the resistance. So the resistance that the heart have in pumping blood out is what we call the afterload. So if you give them something to reduce the afterload, you will now move the curve even further closer to the normal curve, okay? And hence you get much greater output. So when we treat these patients with heart failure, the diuretics is only for symptom relief. It's going to move them from an unfavorable position on the Frank-Starling curve to a more favorable position. And then if we give them something that's going to increase contractility, we trace a new curve to the left of the failing curve. And if we give them an afterload reducing agent, then we also get a curve closer to the normal curve with much more favorable hemodynamics. Okay, so that is the rationale for therapy. So it's not just we pick a bunch of stuff out of the air and try it. You know, we use the pathophysiology and the graphs to help us to treat these patients. Okay, so this is your okay. Now this is what we call the force tension curve. All right, so this is our force tension curve. Force, and you just have to understand two curves to treat these patients. So the force tension curve. So again, only if you know three curves, you know how to treat these patients. So this is the force tension curve, and with the force tension curve, we have the stroke volume, vertical axis, and horizontal axis. We have the afterload. Again, remember the afterload is the resistance that the heart encounters when it pumps blood out. If there weren't any resistance, I mean, the blood would just be going nonstop and everything would be great. But, things doesn't work like that. So there is resistance. And that resistance is what we call the afterload. And then this is the stroke volume, the volume of blood that pump out of the heart per beat. So what this curve is telling us that when and it's a sort of exponential curve. So at this afterload, which is a fairly high afterload, okay, so the afterload increases from left to right. So at this afterload, you're gonna get this output stroke volume, okay? So if you lower your afterload, you get much real output from the heart. So the lower the afterload, the greater the output, okay? So, so you can lower the afterload tremendously, the output will get more. So this helps us also very important in treating these patients, because if we give a medication that can lower the afterload, the resistance for the heart, the resistance against which the heart have to pump blood, then the cardiac output will improve tremendously. And this have tremendous clinical implication, because you may see a patient with a systolic blood pressure of 80, and if you don't understand the pathophysiology, you will run away from afterload reducing agent, whereas that is the medicine that's going to give them maximum relief from their symptoms. So if the pressure is 80 and you can reduce that pressure from say 80 to 70, and you reduce the afterload from here straight down to here, that patient will sit up and tell you they feel much better. So you have to understand the pathophysiology in order to treat these patients effectively. So significant reduction in afterload will swing that Frank-Starling curve to the left, okay, giving rise to a much more favorable output from the heart. So this is the force tension curve. And then, so the only three curves you need to know is your Frank-Starling, the force tension, and then the last curve we're going to talk is your pressure volume loop. And people doing exams need to understand the basics. They don't want you to understand anything tremendous, just the basics. But again, if you're going to treat patients, you need to probably have a little bit more knowledge than just the basics. Okay. So this is the other curve. Okay. And this is what we call the pressure volume loop. So the pressure in the left ventricle is right here, and the volume in the left ventricle is right here. So the pressure is on the vertical axis, and on the horizontal axis, you have the volume. And it's a simple concept. So what we did is to put the complete cardiac cycle in a loop. We put the complete cardiac cycle in a loop. So this is where the mitral valve opens. And when the mitral valve opens, okay, there's going to be a certain amount of blood. So again, this is the volume. So when the mitral valve opens right at this little point here, this is end systolic volume. So the blood is the heart already contracts and force significant amount of blood out, and the aortic valve is now closed, and the mitral valve opens right here. When the mitral valve opens, then the heart is going to fill with blood. So you can see the volume moves from right here to here, where the heart fills with blood. And what you realize is that the pressure in the LV gradually go up, not by a lot. Okay? So in diastole, the pressure in the LV just goes up slightly. And this is what it normally looks like. But after the LV fills with blood, then the mitral valve close. Okay, so it's just a cardiac cycle. So we're not talking, this is nothing new. After the LV fills with blood, then the mitral valve close. When the mitral valve close, the aortic valve is still closed. The aortic valve is not open yet. There's this period of time when the mitral valve is closed and the aortic valve is still closed. And you see this straight line, this is what we call isovolumic contraction time. Because all the valves are closed, the volume is not changing. The pressure is increasing because the heart muscle is tensing the heart muscle is contracting, but the aortic valve is not yet open. So mitral valve opens, the LV fills with blood, the mitral valve closes, the heart starts to contract, but the aortic valve is not yet open. This is what we call the isovolumic contraction time. Then the aortic valve opens, then it's going to eject blood out of the LV, and that is why the volume is going to move from, this is your end diastolic volume, and the volume is now going to decrease to your end systolic volume because the aortic valve opens, blood is ejected from the LV, okay, and then the aortic valve closes. The mitral valve is still closed. It's not open yet. The muscle starts to relax, however, but the volume is not changing. And this is what we call the isovolumic relaxation time or period, because there's no change in the volume. The pressure is going to decrease because the heart muscle now starts to relax. And then the mitral valve opens, the LV fills with blood, and the cycle continues. So the difference between your end diastolic volume and your end systolic volume is the stroke volume. So this is your stroke volume. So this curve, you can get a lot of information on your curve. You know, we can get your end diastolic pressure, your end diastolic volume. This is the isovolumic contraction period. And then when the aortic valve opens and the LV contract, the pressure is going to go up a little bit. This slope is very important. This slope tells you about the contractility of the heart muscle. Okay? This is your end systolic pressure volume relationship. This gives you information on the contractility of the heart. This curve right here, it gives you information on the diastolic property of the heart. This is your end diastolic pressure volume relationship. So if you want to look at contractility, you look at this slope. If you want to look at diastolic property of the heart, you look at this slope. But, you know, this is just putting everything together, the complete cardiac cycle, and looking at it as a loop. And the importance of that is when you get something looking like this, this is the normal pressure volume relationship. You know, same thing we talk, mitral. So this is the normal heart. The mitral valve opens, LV fills with blood, mitral valve closed, your isovolumic contraction time, the aortic valve opens, blood is ejected, the aortic valve closed, isovolumic relaxation, and then the mitral valve opens. So this is, and the difference between, so the width of your curve is your stroke volume. The width of the curve is the stroke volume. And remember, we said that this line tells you about contractility. This is your end systolic pressure volume relationship. This is the curve of a failing heart. So this is the curve of a patients with heart failure with reduced ejection fraction. So people who are doing exams, they're going to put these two curves, and they'll tell you that this curve is normal, and they'll ask you, so they'll say A is a normal pressure volume curve, and B is what? And they'll give you a number of scenarios. But if you understand the pathophysiology, the volume here is huge. The end diastolic volume is huge. It's larger than this one, much larger. The end systolic volume is also increased. Not only that, but your end diastolic pressure is increased. This pressure, this for the normal heart, this end diastolic pressure is right here. You know, so this is your end diastolic is right here. So the pressure there is, okay, this is just size, doesn't want to write. All right, so, all right, let's do it again. All right, so this refused to write, but, okay. So at the end diastolic volume, the pressure is right there. This is, you know, so it's a normal curve, very minimal pressure, as opposed to the failing heart. At the end of diastole, the pressure is right there, and this is why the heart fails, because your filling pressure is greatly increased. Okay, so your end diastolic pressure is increased, this, sometimes the systolic pressure in the heart is increased, but one of the things you're going to find is that your stroke volume is going to decrease. I know they draw this curve having similar width, but in essence, the width would be much reduced. It would be like this, because remember the width of your curve tells you about volume. So in essence, so you'll get a curve with the end-diastolic pressure increase. The width would be much less than that, because the width is a stroke volume. Stroke volume is essence the output, because you multiply the stroke volume times the heart rate to get cardiac output. So the output is going to be reduced. Okay, the output is going to be reduced. And the important thing is to look at the slope. So remember, we said that this is the end systolic pressure volume relationship. For this slope, this is a less steep slope than this one. So the steeper the slope, the better the contractility. This is a much flatter, or not as steep as this one. So you get a decrease in contractility. And you can also look at the diastolic property and see what's going on there. So we give you this background information because once you go into pharmacological therapy, you need to understand the pathophysiology, because everything we do should result in a favorable response in the pathophysiology. And again, diuretics, the only thing diuretics does is for symptom relief. Okay, so you're not gonna you don't expect to get mortality benefit from your diuretics. Okay, so all right, so let us stop here, and on Thursday we'll go into the pharmacology treatment of heart failure. All right. So you can, especially people doing exams, you can review this, because and people who are treating heart failure patients need to review it as well, because a good understanding of the pathophysiology and what you do and why you do certain things is very important. Okay? All right. Good night.